Temporomandibular joint. As the term implies, the temporomandibular joint is a joint which is formed by mainly two bones. One is from the maxilla, and that is called as the temporal bone, and the other one is called as the mandibular portion or the condylar portion, that is from the mandible. So this joint, when compared with the other joints in our body, the temporomandibular joint is actually unique in its nature. As actually there is a right side and there is a left side joint, but both joints cannot work independently. These two joints work as a single system or single unit. That's the uniqueness of this joint in our body. And this joint is also called as TMJ, and the other name is GLENOID joint. Why this is called as GLENOID joint is right because it shows GLENOID means the sliding type of movement in the lower compartment, and diarthroidal joint means, as I said earlier, two joints that shows a rotational type of movement. So each type of movement and a rotational type of movement is done by the same joint. So like I said earlier, temporomandibular joint is a joint which is formed by two bones, one from the maxilla and another from the mandible. And there are actually two joints, but whatever it is, this two joint has to work on each other like a single unit, and it cannot function independently like any other joints in the body. And many a times to our daily routine clinical practices or to our OP section, patients will be coming with the complaints of clicking sound while opening the mouth or closing the mouth. Sometimes there will be pain while patient opens or closes the mouth. Some people will come thinking it might be a dental pain to meet a dentist or the oral physician. And when we check inside the oral cavity, you cannot find any type of problems or details related with the causes like dental pain or periodontal pain, and finally you end up thinking it might be the temporomandibular joint related disorders. And actually speaking, the diagnosis of temporomandibular joint disorders is very complex and it's very difficult. Even if you diagnose the disease which is related with the temporomandibular joint, the treatment modalities are also something very complex. And we can find that the patients who seeks an opinion or advice for this type of diseases might have visited many physicians, orthopedicians, dentists, orthodontists, prosthodontists, and many attend to them. They even the physiotherapists, because this type of disease, the TMJ related disease, is actually very difficult to treat, and it is very difficult to convince the patient and to satisfy a patient by any treatment for the TMJ disorders. Why? Because temporomandibular joint is actually comprising of the hard tissues, the bones. There is something called the soft tissue that is called as this, and then there is ligaments and tendons. So it's like, and there is something called as muscles of mastication. So the opening and closing of the muscles, the mouth is actually managed by the muscles of mastication. The lateral pterygoid muscle helps to open the mouth, while the other muscles like the medial pterygoid and the temporalis muscles, masseter muscle will help to close the mouth. So the muscle which helps to open the mouth or depresses the mandible is the lateral pterygoid muscle. So any damage or spasm to these muscles also will indirectly affect the TMJ. That's one thing. Any occlusal disharmony will also cause dental problems that will indirectly result in damage to the TMJ. The presence of missing bilateral molars, the difference in the chewing patterns, arthritic patients, the patients with hyperactivity of the muscles, hyperextensibility of the muscles. Anything which happens in and around the oral cavity will be having a direct or indirect effect on TMJ. So, as I said earlier, the temporomandibular joint includes both the hard tissues and soft tissues. So, today's topic will be mainly focusing on how to detail examine the TMJ related structures. how to imagine, how to investigate different types of TMJ related factors. So before the advent of CT, now we are blessed with the new technologies like quantum computer tomography. So before the advent of CT, we actually relied mainly on the conventional type of radiography. And the conventional type of radiography actually that is have it's actually have its own limitations. That is one thing. So I can show you one by one the different slides. So as I said earlier, temporomandibular joint is a synovial joint of condylar vertebrae that consists of two parts. One is the temporal part and the other one is the mandibular part. So the mandibular portion of the TMJ is the condylar head, and this condylar head actually articulates in the temporal portion of the, or otherwise this is called as the mandibular fossa, which is present in the temporal portion of the body. So this picture shows the mandibular portion of the TMJ, and this is called as the condylar head. And above there is the temporal portion. The head of the condyle, the superior portion of the condyle, articulates in this fossa, and this is called as glenoid fossa. So this is an anatomical picture of the condyle, which shows the condyle, and below there is ramus. This is the head of the condyle, and this is the neck of the condyle. Now comes to the mandibular bone, and the head of the condyle, or the superior portion of the condyle, will articulate with the mandibular fossa that is present here. And this protuberances is called as articular eminence. So mandibular fossa is otherwise called as glenoid fossa. It comprises of actually the articular fossa and articular eminence. So this is a cut section of anatomical features of the temporal portion of the TMJ, and this depressed portion is called as mandibular fossa, or is called as glenoid fossa. And this AE comprises of articular eminence, AT comprises of articular tubercle, and ZA is the zygomatic arch, EAM is external auditory meatus. In this picture, I think this will be more clear to you that the condyle, this is the condyle, and this is the temporal portion. Between the condyle and the temporal portion, there comes the soft tissue, and that is called as intervertebral disc, or the disc of the TMJ. And the disc of the TMJ is again divided into two portions. On one side, it is having the retrodistal pad. This retrodistal pad will act as a shock absorber for the TMJ. So whenever there is a excessive occlusal force, or when you bite in hard food substances, the excessive force affected on the joints will be absorbed by this retrodistal pad. So this is actually called as a shock absorber of the TMJ. The next portion of the disc contains the meniscus or the articular disc. From there, it got attached to the lateral pterygoid muscles. And as I said earlier, that lateral pterygoid muscle act as the primary muscles of mastication, which will help us to depress the mandible or open the mandible. So whenever a patient comes with limited mouth opening or trismus, and you explore all the etiology which causes trismus, find out the problem with your lateral pterygoid muscle. The spasm of lateral pterygoid muscle also will end up in trismus or limited mouth opening. And you have down below the styloid process, and there is a syndrome called as Eagle syndrome. So in Eagle syndrome also, there is a problem of pain or unilateral orificial pain that is caused mainly because of calcification of stylohyoid ligament. So this is a magnified image of the temporomandibular joint showing the condyle, the disc portion, and the disc portion and the joints are actually connected with the ligaments like sphenomandibular ligament, stylomandibular ligament, and there is something called as lateral ligament and fibrous capsules. Now the most important thing within the joint is the interarticular disc or the meniscus. The disc itself will divide the TMJ into two, the upper compartment and the lower compartment. The shape of the disc is usually concave in shape. You can see the measurements 10 mm anteroposterior and 20 mm mediolateral. This is the cut section of the joint. Now the disc divides the joint. As I said earlier, the disc divides the joints into two compartments. The superior and inferior compartment. Superior compartment is 3 times larger than the inferior compartment and it contains the anterior and posterior viscera. Inferior compartment encloses the entire neck of the mandible and it divides it into anterior and posterior pieces. So this is the picture of the TMJ and the disc related things contain the superior portion of the disc contains the anterior and posterior recess. Now the disc divides the compartment of the TMJ into a thick anterior band, a thicker posterior and a middle portion of the thin central band. The thick anterior band is attached to the lateral trigger. The thicker posterior band is attached to the vitrodiscal tissue. The thin central bands actually act as an articular cushion between the condyle and the articulated units. I can show you in next picture regarding that. So this is the three divisions of the disc: a thick portion, thicker portion, and a thin portion. So the thicker portion will be continuing with the lateral trigger. Then comes the retrodiscal tissue. It is a shock absorber or the fibrous tissue which will absorb any damage or sudden shock happening to the TMJ, and it contains the synovial tissue, synovial membrane, and that will secrete the synovial fluid and it will be able to joint. So all the pictures are present here. The thinner portion is there here, and the anterior portion of this one. This is the lateral pterygoid muscle. The posterior portion of the disc is attached finally with the retrodiscal pad or the shock absorber. Now there is something called as different movements of the disc and condyle. So that I can show you later in a small video. So coming to the goals for imaging, why we actually image a TMJ? What is the purpose of doing imaging investigation for TMJ? The first thing is to evaluate the integrity of the structures. Structures, it is the hard tissues, that is the bones of the TMJ. Structures, that is the soft tissue, which contains the disc, the muscles of mastication, the tendon, the ligament, all these things. Next is to determine the extent of disease if it is present or not. Next is to monitor the progression of the disease and monitor the effectiveness of the treatment and exclude any other causes or etiologies which mimic like TMJ pain. That is like Eagle syndrome, and there is migraine, cluster headache, trigeminal neuralgia, chronic pulmonary diseases. All these things also will mimic like the pains in the TMJ. And various factors actually influences imaging the temporomandibular joint. That is a specific problem which is given by the patient on the symptoms. From the symptoms itself, actually, it is very difficult for a clinician or physician to identify what is the actual cause or problem of the patient. And when we actually reach into a conclusion, then only it will be helpful for us to send the patient for an appropriate investigation, whether the problem is based on the soft tissues or based on the hard tissues. And if it is related with the soft tissues, we have only two choices, that is the ultrasound and magnetic resonance imaging. And for the hard tissues, we have many choice. It includes a start from the basic pain radiography and till the conduit computer. And to know whether the lesion or the disease is active stage or in passive stage, we have radionuclide imaging, explaining single photon emission computer tomography. And the diagnostic information available from all this scanning is very important. And also, when we check a patient, we have to see the budget or the economical background of the patient for sending the patient for particular examination or investigation. And some cases, for example, MRI is actually contraindicated in a patient with the usage of pacemaker. So then there should be, we have to think of other options for sending this patient for MRI. So these are the contraindications and availability of the equipment in our locality. So starting from the plain film radiography for temporomandibular joint, the first three things, that is the transcranial, transpharyngeal, and the transorbital. These three imaging techniques are the old school techniques of temporomandibular joint imaging. And even in Viva or in case of anything, any of the clinicians or professors ask a question like what are the most common temporomandibular joint imaging, they expect you to answer these three points: transcranial, transpharyngeal, and transorbital. Submendovertex is also used for identifying the fracture of the TMJ. That is one thing, and it is also used to identify the modus perturbation is used for identifying the fractures of the adenopathic arch, and there is the reverse nose projection, and you have orthophenomegram or OPG, conventional tomography. So these are all types of techniques comes under plain film radiography. Then you have advanced imaging modalities. Advanced imaging modalities like the computer tomography, where the advanced techniques like quantum CT imaging is there. Then you have magnetic resonance imaging, nuclear medicine. For nuclear medicine, we have SPECT. The full form of SPECT is single photon emission computed tomography. Then you have PET. PET is called as positron emission tomography. These two things are commonly called as radionuclide imaging, which uses radioactive isotopes like iodine, technetium pertechnetate, that is injected into the body, and with the help of gamma X-rays, the activity of these radioactive isotopes are calculated in the body. And if at all any abnormalities are there within the body, or if any abnormal cells are present in the body, they actually take up these radioactive isotopes and they will be seen in an active stage or in a passive stage. The other imaging modalities for TMJs are ultrasonography, and ultrasonography is a real-time imaging scan exclusively used for finding the soft tissue abnormalities of TMJ, especially the disc-related things. Then we have arthrography and arthroscopy. Now, coming to the discussion of each techniques, the first we'll start with transcranial view. This is also called as Schiller's technique. This type of transcranial view is used to identify the sagittal view of the lateral part of the condyle and the temporal components. Here, the X-ray is actually directed parallel to the long axis of the condyle. I can show you the picture. So this is the picture. When we take, we have to see. Remember, this transcranial, transpharyngeal, and transorbital technique. All these three techniques can be done with the help of a normal dental X-ray machine and a dental chair. So this is the position of the patient. The patient has to sit upright or stand upright. We are supposed to keep the X-ray film in one side, and we have to project the X-ray from the opposite side. You can see how the X-rays are coming from the opposite side. And why it is called as transcranial? Because the X-rays which is coming from the opposite side is passing through the cranium. That's why it is called as transcranial. Above the petrous ridge of temporal bone. So the X-rays are coming through the cranium above the petrous ridge of temporal bone, and it finally hits the sagittal part of lateral wall of the condyle on the opposite side, and the information regarding that will be carried to the casket. The angulation is very important. The horizontal angulation should not be more than 10 and the vertical angulation should not be more than 50. Now this point is very important. The film is actually positioned against the facial skin on side of the interest parallel to the cervical plane and the X-ray tube head is projected from the opposite side. The central beam of the X-ray is also projected downward 25 and centered over the image. So this is one pictorial presentation of transcranial view. You can find the patient is standing or sitting in a normal upright position. The cassette is placed on one side, and to attain this TMJ region, we are going to keep the X-ray tube on the opposite side. From the opposite side, at an angulation not more than 25 degree and a horizontal angulation of not more than 10 degree, the X-ray tube is kept. From the X-ray tube, the X-ray beam which is produced will pass through the cranium above the petrous ridge of temporal bone and will be hit onto the region of TMJ, that means the surgical of the lateral part of the contact. And this technique can be taken in two different types of methods. That is the open mouth technique and the closed mouth technique. If you ask me what's the difference between these two, the open mouth technique will always help us to reduce the superimposition of different structures happening in and around the team. So it is always best to get an open mouth technique. Open mouth technique will help to reduce the superimposition of other structures. So this is the radiographic image after attaining a transcranial view. You can see from these both pictures. In one picture, this is the open mouth technique. You can see the distance from the glenoid fossa to the condyle, and this is the closed technique. You can see the distance from this. This is an animated image of transcranial view. So the main disadvantage of transcranial view is that any deviation in the horizontal axis will result in distortion of the image, and any deviation in the vertical axis, that is the not, I have told you that not more than 25 degrees. So any deviation in that position will result in foreshortening or elongation of the contour, like how you take the bisecting angle technique for the teeth. And the next disadvantage is superimposition, and to avoid superimposition, we have to do open mouth technique. Now coming to transpharyngeal view. So transpharyngeal view is also called as Palmar projection, McPhee projection, and intracranial projection. This helps to identify the medial pole of the condyle. So always remember transcranial. The X-rays passes through the cranium. So transcranial view helps to identify the lateral port, whereas transpharyngeal will help to identify the medial port. And why it is called as transpharyngeal? Because remember about the pharynx. The pharynx is always situated in the central portion of our body. So think like that. Center, you have to assume the central portion to the medial pole. Like that, you have to remember. So the transpharyngeal view helps to identify the medial pole of the condyle. And hence here, to avoid superimposition, always they prefer to take transpharyngeal and open mouth technique. Now I'll show you the image. You can see the patient. This is an open mouth technique. The patient is sitting in a mouth open position, and the cassette is placed in one side, and in the opposite side, the X-ray tube is placed. And you can see that the X-ray tube is placed a bit closer to the skin. That is one thing. In transcranial, we have kept an angulation of 25 degrees, but here this is some more horizontal. That's one thing. And I'll show another picture. See, this is a marking, and this is the place which is present between the condyle and the coronary process. Within this, there is the sigmoid notch. Here, the marking has been done, and the X-ray is actually supposed to go this. So this is the image. So the patient is positioned like that. The X-rays are produced on the opposite side. That will go like that. between the condyle and the glenoid process to the sigmoid notch, and we hit the condyle on the opposite side. But the X-rays are actually going through the pharynx, through the oropharynx. That's why it is called as transpharyngeal. So you can see here the catheter is in position against the side of the patient head, parallel to the sagittal plane. The tube head is placed on the side of the skull, opposite to the TMJ imaging. The X-ray beam is directed cranially, but it passes through the sigmoid notch below the base of the through oropharynx. That's why it is called as transpharyngeal view. One of the modification of this transpharyngeal view is called as the pharma projection. Before that, I'll tell you this is the image obtained after getting transpharyngeal view. The advantages is that it is easy for us to take this image, and the superimposition is actually less because of the open mouth technique. And if there is no mouth opening, as in case of Christmas or any other pathology, definitely there will be superimposition. And you cannot find any information about the glenoid fossa, that is one disadvantage. And radiation dose is high when the target to fielding distance is short. This is called as pharma modification or pharma projection. So in pharma modification or pharma projection, I'll show you this one. See, here the patient is using an X-ray beam with the help of a position indicating device. But in pharma modification, the position indicating device is removed and the direct X-ray beam will be kept more nearer and near to the skin. This is called as pharma modification. We are doing this is to get the TMJ in a magnified version, and it will also help to avoid superimposition. But the problem is that the radiation dose will be high when we do the pharma modification because the target to filling distance becomes short. And the next thing is transorbital view, and this is also called as transmaxillary or Zimmer's projection. When you compare this transorbital with transcranial and transpharyngeal, here the X-ray tube is actually kept in front of the patient, that is in front of the orbit. So this will help to identify the anterior view of the TMJ. So here the X-ray is actually directed perpendicular to the long axis of Condyle, and it is having minimum superimposition. But the main disadvantage is that it is very difficult to reproduce the image. So here the patient is supposed to sit in an upright position. This is the image. Patient is asked to sit in an upright position. Mouth opening technique is done in order to avoid superimposition. The X-ray tube or the X-ray tube which produces the X-rays are kept in front of the patient, and the cassette is kept behind the patient, and the X-ray passes through the X-ray orbit to the TMJ, existing the skull behind the vascular process. And the image which is obtained by transorbital view is this. The advantages include technique, less superimposition because it is an open mouth technique. The changes can be seen nicely. But the one disadvantage is superimposition in case if there is limited mouth opening and the reproducibility is difficult, and the imaging things are actually less accurate because everything is based upon the technique sensitive. The technician's experience, the patient position, the angulation, everything matters for getting proper accuracy of transorbital. So before going to submit the vertex, I hope we stop the class here and we'll continue the class in the next